Hi, my name's Esther Youd. I'm a histopathologist at the Royal Glamorgan Hospital in South Wales, and I'm going to talk to you a little bit about coronavirus and the autopsy. And I'm going to share with you some of my experience of dealing with some cases of COVID-19 that were found at autopsy.
So I'm going to take you through the autopsy aspects of the coronavirus infection. So I'm just going to give you an introduction, first of all, to SARS-CoV-2. Quickly touch on the typical clinical pictures because that informs what we're likely to see at autopsy. Consider the implications of a pandemic on autopsy practice. To talk about testing for SARS-CoV-2 at autopsy, and then to take you through some cases to talk about some macroscopic and microscopic findings. So to begin with, SARS-CoV-2 is one of a small number of coronaviruses that are known to affect humans. There are 4 that cause a mild respiratory tract infection, and then a group of human coronaviruses that cause significant disease. The first one of these is SARS-CoV-1, which has been renamed with the 1. This was an outbreak that started in 2002/3. This affected 26 countries worldwide, and there were more than 8,000 cases, and the case fatality rate was high, it was about 11%. Then there's MERS, which first emerged in 2012, but there have been cases ongoing since then. MERS has affected 27 countries worldwide, but 80% of those cases are in Saudi Arabia. In total, there have only been 2,519 cases, but the case fatality rate is very high at 35%. And now we have a third human coronavirus that causes significant disease in SARS-CoV-2. So the virus itself is called SARS-CoV-2. The disease it causes is called COVID-19. Which is named after coronavirus disease. The WHO terminology, in order to distinguish this outbreak from the SARS outbreak from 2003, which was centred on China and it has quite negative connotations for China. So the WHO for this outbreak is tending to use the terminology the virus that causes COVID-19. As of 16th of April, there were approaching 2 million cases worldwide, with 213 countries affected and 130,000 deaths. And the WHO keeps a dashboard updated regularly. And this is from their dashboard, and it shows all of the countries across the world, and there's basically nowhere that hasn't been affected. This is what the virus looks like under electron microscopy, and you can see there are a number of spikes around the outside forming like a crown, and that's why it was named a coronavirus. So the clinical presentation, it tends to affect men more than women. The majority of people have a mild respiratory tract infection, but about 20% require hospital admission, and some of those require ITU support for respiratory distress. And this tends to be ARDS. They tend to have lymphopenia, so low lymphocyte counts in the blood. They will get a viremia. Some will show acute cardiac injury, and you can see that with rising troponins measured in the blood. And some will get secondary infections. And things like lymphopenia and rising troponins and also D-dimers are often associated with a poor outcome. So what are the implications of such a pandemic for autopsy practice? Well, the Royal College of Pathologists has guidelines on how to deal with an autopsy where COVID-19 is suspected, and there's a best practice article published in the Journal of Clinical Pathology. So I'm just going to cover these questions. First of all, is it safe to do a post-mortem? If so, how do you do it safely? What are the wider implications that you need to think about when running a service? And how do you continue to provide a regular autopsy service aside from COVID-19? And how might some death certification changes affect autopsies? So first of all, is it safe? Yes, of course it is. But you do need to have the right facilities in your post-mortem mortuary and the right equipment, including personal protective equipment. So how do you safely do a post-mortem? Well, first of all, you need to know what the hazard is, and SARS-CoV-2 is assigned to hazard group 3, which is the same hazard group as SARS-CoV-1 and MERS. This is also the same hazard group as hepatitis viruses and HIV, which we're, I guess, slightly more familiar with dealing with in the mortuary setting. And a well-staffed mortuary with experienced personnel should be well equipped to deal with hazard group 3 autopsies. So you need to take universal precautions, which include proper personal protective equipment. You need to start off, first of all, by assessing the risk. Find as much clinical information as you can. What are the circumstances of death? What information can you glean from GP records or hospital notes or laboratory systems? Basically, get as much information as you can to assess the risk of the case. It can be really helpful to get a checklist of information from the coroner's office. For example, have they had any recent cough or fever, any difficulty breathing, or any contact with a COVID-19 positive person? And in general, those deaths where patients are known to have died from COVID-19 are not likely to require an autopsy because a death certificate will be issued. So in terms of the premises, you need to have good ventilation. Either whole room ventilation or downdraft tables are sufficient. You should have a vacuum on bone saws. Ideally, use of a high-risk suite is great, but it's not essential. You should use experienced staff, so not trainees, not trainee APTs. General attention to how you use sharps is appropriate, and particularly the use of needles and not resheathing needles and proper disposal of needles. And also, if you can find blunt-ended PM40 blades, then that reduces the risk of sharps injuries during dissection. You need proper personal protective equipment, and this will include the basics of scrubs. You need a full gown, a plastic disposable apron, gloves with cut-proof gloves underneath, eye protection, which is typically a face visor, an FFP3 mask or a respirator, and solid boots. So how do pandemics such as this affect the wider service? Well, there are multiple effects. The first one to think about is the potential for staff shortages, and this might affect the pathologists, the mortuary staff, and the clerical staff, all who support the service. People might be unwell themselves with COVID-19, or they might be isolating because they have respiratory tract symptoms, and that might reduce your workforce. You might have body storage capacity issues because of expected larger numbers of deaths, and this might affect the capacity to be able to bring a body in to do an autopsy. There's likely to be an increased demand for autopsies because of a higher expected death rate. And then you should also think about how this increased personal protective equipment affects you. You will tend to get more tired and particularly dehydrated with the FFP3 masks and the full gowns. So do take care of yourself and make sure that you stay well hydrated and take breaks. So how do you continue to provide a service? You really need close communication with all of your teams that support the service. So with the mortuary team, the secretarial team, and the coroner's office. And the best way is to plan for the worst and hope for the best. So about changes to death certification, the new Coronavirus Act in the UK provided multiple temporary changes to the death certification process. Some of those changes include the fact that any doctor can complete a death certificate, not just somebody who was caring for the individual. There is the ability to electronically transfer information, for example, sending a scanned death certificate to the registry office. There's no need for cremation form 5, and there's an extension to the time limit when the patient was last seen. So rather than that being seen within 14 days, that's now extended to 28 days. And this all facilitates greater completion of death certificates and potentially reduces the demand for post-mortems. So a word about testing for SARS-CoV-2 at autopsy. There are a number of different approaches. Some will advocate swabbing prior to the post-mortem, and this is by taking a nasopharyngeal swab. And this could help you with risk assessing an individual case. There are problems with this, though, because we don't know what the sensitivity of testing at post-mortem is. And if you have assessed on the basis of clinical information that there is a high risk of COVID-19 infection, then if you were to swab and had a negative result, it wouldn't be sensible to rely on that negative result and therefore not take the extra precautions. If you clinically feel that the case is high risk, because of the unknown sensitivity, you would need to proceed with the post-mortem, taking all precautions as if it was high risk still. So because of that, I don't think swabbing prior to post-mortem is necessarily particularly helpful in how you then approach the post-mortem. You can take swabs during a post-mortem, and we get excellent access, obviously, to the lower respiratory tract than can be sampled and accessed in life. So it's quite easy to open up the trachea and take a swab, or to take a swab from the lung tissue once you have sliced across it. Again, we don't know what the sensitivity of swabbing is at post-mortem, but there are plenty of examples of where positive swabs have been obtained up to 9 days after death. So it is possible to find a positive result. Some people advocate not swabbing at all, but I would say that's not very sensible, because you then won't be able to determine whether the changes that you see at post-mortem are attributable to COVID-19 or not, given that it doesn't actually produce specific histological changes. So I would say that swabbing is important. If, however, you're unable to take swabs, or you didn't take swabs at the time for whatever reason, and then you see histological features that suggest COVID-19, you can perform PCR testing on samples from formalin-fixed paraffin-embedded blocks. So this is also a useful tool for pathologists at a later date. So these are the described typical macroscopic findings that chiefly affect the organs in the chest. So in the lungs, you might see pleurisy, consolidation of the lungs. You might see frank pneumonia, where you have a bacterial infection superimposed on a viral infection. You'll probably see associated pulmonary edema, and you'll probably see inflammation of the large airways. In the heart, you might see pericarditis or changes of myocarditis, although myocarditis is much more difficult to assess with the naked eye. The image on the right shows an example of a fibrinous pericarditis, and you can see all these pale areas over the surface of the heart are deposits of fibrin, and then the background is very inflamed and red because of inflammation of the surface of the heart. In terms of microscopic findings, the chief hallmark of the damage that occurs in the lungs is diffuse alveolar damage, and this is the histological correlate of adult respiratory distress syndrome. You will see lymphocytic infiltrate, which is typically associated with viral infections. You will see type 2 pneumocyte hyperplasia and shedding, and this can be really quite dramatic. And you may see, of course, superimposed bacterial infection. So just to take you through a few cases. The first case is an 80-year-old female who was a care home resident, and she was found dead suddenly. She'd had no prior symptoms, so the cause of death was entirely unknown, and the death was completely unexpected. At the post-mortem, both lungs looked like they had lobar pneumonia. So the lobes were very, very solid. They had a typical red hepatization appearance on cut surface, and were very firm. The COVID-19 swab taken at post-mortem was positive. And this was the microscopy. So on the lower power here, you can see a markedly altered architecture of the lungs. This looks very, very solid and very cellular. On the slightly higher power now, you can see different features of diffuse alveolar damage. So to begin with, there are fibrin membranes forming here. So the pink fibrin deposits lining the alveolar walls. There's a beautiful one here. So these are the typical fibrin membranes seen in diffuse alveolar damage. In the background, there is widening and thickening of the interstitium with loads and loads of lymphocytes infiltrating. And in the alveolar space, there are lots of cells that have been shed into the alveolar space. And the majority of these are type 2 pneumocytes, which we'll see closer up in another section. So again here in close-up, you can see the fibrin membranes lining the alveoli, the lymphocytic infiltrate in the interstitium, and lots of type 2 pneumocytes being shed. Here in the closest view, you can see this enlargement of the type 2 pneumocytes. These are usually really small and indiscrete, but here they are markedly enlarged with large nuclei and large nucleoli, and some of them are dropping off into the alveolar space. You can distinguish them from macrophages, which have a much more bubbly cytoplasm. And here again you can see that lining of fibrin membranes of diffuse alveolar damage. So the second case is a 76-year-old male, again, who was a care home resident. He was generally unwell, not really himself. He did have a cough, and on one occasion he was noted to have a fever, and he'd been prescribed antibiotics by his GP. His swab at post-mortem was also positive for COVID-19. And this is his lungs. And this case looks slightly different from the previous one, but there are still some similar features. So there is less thickening of the interstitium than the last case, but you still can appreciate that these walls of the alveoli here are much, much thicker than they should be, and much more cellular. So you can appreciate lymphocytic inflammation in the background, in the interstitium, in these widened alveolar walls. You can see fibrin within the alveolar space, and some of it forming fibrin membranes lining the alveolar space. Again, on the higher power, you can see these fibrin membranes. You can see the type 2 pneumocytes enlarged and being shed into the alveolar space. And again, you can see the thickening of the alveolar walls here with lymphocytes present. This shows similar features with deposits of fibrin and with type 2 pneumocytes, and in the background lots of lymphocytes in the interstitium. And this was this chap's heart, which shows an interesting feature. Here you have a number of multiple lines across these cardiac myocytes, which are contraction bands. So there's quite widespread contraction band necrosis in this heart. The third case was a 78-year-old female whose husband had died in hospital of COVID-19, and then she died at home. She had consolidation of the lungs macroscopically and an inflamed trachea, and a COVID-19 swab taken of the lungs and trachea was positive. In this case, again, you can see changes of diffuse alveolar damage. You can see fibrin production and fibrin membranes lining the alveolar spaces. You can see thickening of the walls of the alveoli. And there is lymphocytic infiltrate, but in this case it's quite a bit less cellular than the two previous ones. So here again, very typical fibrin membranes lining the alveolar space, changes of diffuse alveolar damage. You don't really see the changes of pneumocyte hyperplasia and shedding in this case. And just slightly closer, again, you can see these fibrin membranes lining the alveoli. But if you look in the background interstitium, although this is thickened and widened much thicker than you would expect, it's not quite so cellular, and it's harder to pick out lymphocytes in this case. but they are there. So again, some beautiful fibrin membranes and then lymphocytes in the background, but fewer in number. And then finally, the fourth case is an 87-year-old female with a sudden shortness of breath and collapse. An ambulance was called, but there was no response to CPR and she unfortunately died. With the naked eye at autopsy, there was evidence of bronchopneumonia with associated pulmonary edema and a background of marked emphysema. And her lungs look like this. So there is thickening of the alveolar walls here, but it's a lot more subtle than the previous cases. But still, these walls are 2 or 3 cells thick, when really there should just be 1 cell thick to allow for good gas exchange across the alveolar space. So these are thickened alveolar walls, and there are lots of lymphocytes scattered within them. So these are cellular and thickened, and the lymphocytes are very typical of a viral infection. In some areas, lymphocytes are a lot more prominent. So here, quite a lot of lymphocytes present. And then in areas, there are quite large clumps of fibrin within alveolar spaces. In some places, these were lining the alveoli as well, forming typical fibrin membranes, but a lot of it was these big clumps of fibrin, and some of them have lymphoid cells scattered within them, and here in the background you can see lymphocytes in the interstitium. Again, here you can see a big clump of fibrin within this alveolar space with a multinucleated giant cell in the middle there, and here it's forming a more typical fibrin membrane lining the alveolar space. This one, however, was a rhinovirus case. So this was not COVID-19. The COVID-19 swab was negative, but it did test positive for rhinovirus. So this just illustrates that viral infections of the lung still occur at this time. Not all the viral infections in the lungs are COVID-19, and there are some similar features that can be seen, although I think with quite advanced COVID-19, as in the first case, the features are, the collection of features are really quite typical of COVID-19. So take-home messages. SARS-CoV-2 is a hazard group 3 organism. You can do an autopsy as long as you've got suitable premises and equipment. Testing for COVID-19 is really important at post-mortem, and it can make a real difference to the health protection teams. So for example, the 2 cases that we've talked about where they were care home residents, it was really important that the health protection team had that information and were then able to put in additional support to that care home, which is considered to be a closed setting and therefore in need of additional support to prevent more widespread transmission of the infection in that setting. Histology of the lungs and heart are going to be the most important, and there are many clinical descriptions of myocarditis, although that hasn't been seen so far in my practice. And just remember that not all viral infection in the lungs is COVID-19. Thank you very much.